Good morning, everyone. Bob Ravenscroft, the Vice President for Advancement. Hard to believe we're here for media briefing number 62. A couple of, as usual, we'll go over some stats. I have one quick announcement, and then we'll get right to Dr. Jim Nora. The first announcement, we're going to relax some of our visitation procedures going into effect on Monday. The main one, there'll be a few of them announced that we'll share next week, but the big one I think is we're relaxing the hours of when a support person can visit their patient. It was 5 a.m. to noon. It's going to be 5 a.m. into the evening. I believe it's 8:30, right, Edgar? Yeah, 8:30. And then we're also relaxing who can visit. It is still one support person per patient per day, but it's no longer just one support person. So families can split it up for those longer stays and get more people in to see their loved one. Quickly before the stats, we had mentioned long ago that we were in this for the long haul until the availability of testing was in place, there was better contact tracing, and then ultimately a vaccine. So in the kind of meantime, we've been strong advocates for universal masking, hand hygiene, social distancing, all of those things that everybody is aware of. We remain strong believers in that it's vitally and important to mitigating the spread and preventing us from backsliding and seeing what's happening in other parts of the country. We all want things to be normal by the fall. So please mask, social distance, and hand wash. Again, there's been tons of questions throughout this period on testing as things have been developing, and Dr. Nora, who has appeared on these briefings before, will give an update on serology testing and some advances that have been made there. So before we get to Dr. Nora, our midnight census was 460 patients. We have now administered 12,541 tests through Bryan. Our positives are 1,574. And we have 381 pending results. Right now, we have 8 COVID-19 patients in Bryan Medical Center. 7 are from Lancaster County. 1 is from outside of the county. Number on vents remains at 3 as it did yesterday. Of our positives, 5 of them are in intensive care. 1 of them is in our PCU, and then 2 are in general care. So with that, let's get right to the main event and have Dr. Nora tell us all about serology testing.
Good morning. Thanks for having me today. Serology testing is a hot topic, and I understand there have been lots of questions about this, and I certainly get lots of questions about this in the hallway around the hospital. It's an area of constant change. So I wanted to give an update, really an update on testing in general, because that's what this is all about, is how do we test and diagnose and make sure we're getting accurate information for public health officials and for patient care. So the test that has traditionally been used is the RT-PCR test, and that is the nasal swab. And really, that is going to remain the main test that 99+% of people are going to be using for the foreseeable future. It is possible that down the road there will be a great serology test. Right now, we don't have that. But eventually, there's that possibility. So for now, from a practical standpoint, if you're a patient, if you have a loved one that needs to be tested, the test that person will be receiving will be the traditional PCR nasal swab test. Well, let me talk a little bit about serology tests, because that is something that continues to come up. A serology test is an antibody test. So this measures whether or not an individual has been exposed to SARS-CoV-2, and if the test is positive, then we have confidence that there's been a prior exposure. That's how it's supposed to work. Serology tests in general, antibody tests, only work when the host, the patient, produces a good antibody response to the infection. This typically takes 10 to 14 days, so if you test too soon, then you're going to get a falsely negative test just because you tested too early. There are lots and lots of infectious diseases that serology tests works really well for. So chickenpox, CMV, EBV. So if somebody's had mono before, that we use a serology test to look for mono. West Nile virus, Rocky Mountain spotted fever, ehrlichiosis, things that are very common this time of year. All of those we can test with a serology test, and it works really, really well. COVID-19 serology testing does not work well. It is not understood at this time, and its applicability to a particular patient is very difficult to ascertain. So the immune response to SARS-CoV-2 is complex, and we now understand that there are a number of individuals, many individuals who get exposed to this virus who end up having no symptoms at all. And it turns out that those individuals actually have some immunity that is provided by other respiratory viruses. And it could be another coronavirus, or it could be another respiratory virus from a different family altogether. But those other viruses may provide some cross-reactivity, some protection against SARS-CoV-2. So asymptomatic individuals may have a small spike in an antibody towards SARS-CoV-2, but they may have none at all, and it may not last for a very long time. When patients have true infection from SARS-CoV-2, so they're sick, they have fever, cough, shortness of breath, all the classic symptoms that we look for, they will eventually develop a good antibody response, and how long that lasts, we still don't know. So the bottom line is serology testing for SARS-CoV-2 is complex, and it really will not have a large role in individual patient diagnosis, at least in the near future. Keep in mind that this is really true for pretty much all respiratory viruses. So we finished our influenza season a couple months ago. We don't diagnose influenza with a serology test. We don't diagnose other respiratory viruses like RSV, adenovirus, metapneumovirus, all of these other respiratory viruses. We don't use a serology test for those either. And as a general rule, serology tests are less useful for respiratory viruses. So I think it's not necessarily a good expectation to think that we're going to have a great serology test for SARS-CoV-2 when we don't have good serology tests already for most other respiratory viruses. So when would we want to use a serology test? And the role for serology testing may primarily be from a public health standpoint. So if we're investigating how many people in Nebraska have had exposure to SARS-CoV-2, having a good serology test is a way to do that. Unfortunately, as we just talked about, the immune response to SARS-CoV-2 is complex, and people who have no symptoms may really not have a good immune response to it. That's in terms of the SARS-CoV-2 antibody. They have had other antibodies that have helped to protect them. So even from a public health standpoint, this particular test is already mired in difficulty and controversy. The hope is that there will eventually be a very, very specific test that has been heavily validated and can be used on a public health standpoint basis to give us a good sense of how many people in the community at large have been exposed to this. But that would be one potential use for a serology test. Another potential use is in screening individuals for possible donation of convalescent plasma. So one of the important treatments that we have right now for SARS-CoV-2 is we give patients the convalescent plasma from somebody who's recovered from SARS-CoV-2. So patient had SARS-CoV-2, had symptoms, and ended up recovering. They're 30 days out. We can collect their serum and then administer that to another patient. So essentially that the new patient is getting antibodies from the previous patient. And the hope is that helps to lessen the course. So that would be another role for using serology testing. In terms of clinical practice, the only real role that I see for it, for serology testing at this point, is in very rare circumstances where somebody may be presenting late, they've already been through a couple of the routine PCR tests, and those have been negative, and yet we still want to make a definitive diagnosis if we can. This will help with contact tracing. It could help with just reassurance to family and the patient, and to make sure we don't need to do unnecessary workup for other potential infections. So in that limited circumstance, there may be a role for serology testing, but really, again, the vast majority of testing will continue to be with the RT-PCR, which is the nasal swab. In terms of the future for that test, I would like to just make one comment that there is ongoing investigation of a saliva test. And what that is the patient would have a cup of water, 4 ounces, 8 ounces of water. You drink that, gargle it around, and you spit it back into a cup. That test is being actively developed and is in use in some parts of the country, but not so far in Nebraska that I'm aware of. And we don't really have a lot of published data from the CDC giving us specifics about sensitivity and specificity yet on that. But that would be a nice replacement or adjunct to the RT-PCR test. That also uses PCR technology. It's not a serology test, but in many circumstances, it would be nice to have that saliva test, that test, instead of having to have the nasal swab to the back of your nose. So with that, those are some of the questions or some of the topics I wanted to update. I would be happy to take some questions if this is a good time for that. Bryan has already done serology testing on a few select patients, and when I say Bryan, what I mean is that our lab collects them and sends them out to a reference lab. So there are very few places in the country that have their own in-house serology testing. So yes, we have done some serology testing for those unusual clinical circumstances when somebody's had multiple negative PCR tests and we're still trying to make a diagnosis, and those have been sent off to a reference lab. No, I think it's important to maintain a high level of testing when there's spread of an epidemic or pandemic illness. We want to make the diagnosis as quickly as possible and then do contact tracing. From an infectious disease standpoint, it would be ideal if we had in-house testing at every hospital and maybe even every clinic. Right now, we're lucky at Bryan. We have a number of in-house tests that we do, and we also can send out to a reference lab for testing. It would be great if we could constantly have a short turnaround time in-house test and have adequate supplies. We have maintained supplies, and that's the laboratory working very hard with our suppliers, trying to make sure we're constantly resupplied. But it's been a challenge. And we would love to have adequate, plentiful, rapid turnaround testing at our hospital, and I think every hospital in the state, and potentially every clinic. We are not at that level yet. We do have testing in-house, and again, I think it's very important to maintain a vigilant level of testing as long as there's epidemic spread. One of the important public health uses of serology testing. And for example, for West Nile virus, that's an easy question to answer. We can do a survey of certain random individuals within the population, and it's a serosurvey, just measure who's been exposed to West Nile. Unfortunately, for COVID-19, things are much more complex. So it's possible that a serosurvey will significantly underestimate the percent of the population that's been exposed, especially when we have lots of asymptomatics, and those asymptomatics may not have the standard antibody response. So yes, that would be a great tool to have, and I know our state public health officials would love to have this, and I'm sure they'll be trying to use this as a tool, but it's important to understand, due to the complexity of the immune response with this particular virus, that those serosurveys may underestimate the actual exposure to the population at whole.
I do want to look that up and confirm for you. I know that, it was probably 3-4 weeks ago, we gave an age breakdown, and one of the big misconceptions here at Bryan, the majority of our cases were between like 35 and 50 years of age, and some of our most compromised patients have been skewed younger. So obviously there's been concerted efforts to keep it out of long-term care facilities because of the obvious reasons, but the impact locally as far as positives has probably been skewed a little younger than most people understand. I will get those numbers and we'll bring that back to you.
So I think it's probably most accurate to say that the case count in Lancaster County has been stable over the last several weeks. If you look at the case count last week in Lancaster County, it was actually slightly higher than it was the previous week. But overall, we've seen a nice trend downward since we had our peak. So the way I would interpret it is that right now things are stable in Lancaster County. Now, if things had been different, if we had continued very aggressive closures, maybe we would see a further decline at this point. The important thing is whether, regardless of what our opening status is, if people are wearing masks, that provides a tremendous amount of protection to the population at large. So the higher the percentage of people at large who wear masks out in public, we will definitely see lower numbers in terms of our case count per week. If in terms of younger folks coming into the hospital, we've certainly seen some younger individuals in the hospital. The factors that drive whether somebody gets hospitalized or not are, I think, twofold. One is their age, and we know that clearly older individuals are at higher risk of getting hospitalized and doing poorly with COVID-19. A second risk factor, though, is the amount of exposure or the intensity of exposure. So if a young person is in a confined area and there's lots of coughing, sneezing, and nobody's wearing masks, that's a way for a young person to get a high exposure. So even though the younger person may be healthier at baseline and may be less likely to be vulnerable to COVID-19, because they get a very high exposure, that can be a reason that they end up in the hospital. Unfortunately, there has been some politicization of masks, of other aspects of COVID-19, and the state call yesterday that I participated in, that a number of folks around the state, healthcare professionals, participate in. This was a topic that was discussed, and we would really encourage people to depoliticize the mask. Wearing a mask doesn't, it doesn't matter what political beliefs you have. There is good medical scientific evidence that masks help to prevent infection, spread of infection. So wearing a mask is a way for individuals to protect themselves, and really more importantly, it's a way for us to protect the most vulnerable members of society. So a lot of young folks who are out and about, if they wear masks or don't wear masks, they may think, well, if I get it, it's not that big of a deal. And for the most part, they're probably right. Young people do tend to do well with this virus. But the problem is, if a younger person gets COVID-19 and maybe they have a couple sniffles or very minimal symptoms, but then they go and visit grandma or grandpa, then that individual is at high risk of acquiring COVID-19 from their grandchild, and grandma or grandpa may not do well with it. They may end up in the ICU and they could even die from it. So in thinking about whether you want to wear a mask or not, think about wearing a mask for protecting other members of society, particularly the most vulnerable members of society.